CNA hand hygiene technique. Welcome to the quiz. Question 1. The BOTUS primary buffer system in the extracellular fluid is the Option A. Phosphate buffer system. Option B. Protein buffer system, especially hemoglobin. Option C. Bicarbonate carbonic acid system HCO/HCO. Option D. Ammonia/ammonium system in the kidney. The answer is C. Buffers are solutions that resist changes in pH when acid or base is added. The bicarbonate carbonic acid system HCO/HCO is the most important buffer in the extracellular fluid ECF, which includes blood plasma and interstitial fluid. Its importance stems from 1. High concentration. Bicarbonate is present in relatively high amounts 24 milliequivalent/L in plasma. 2. Open system. It is an open buffer system because its components are regulated by the lungs and kidneys. CO, which forms HCO, is volatile and can be excreted by the lungs, and HCO can be regenerated or excreted by the kidneys. This allows for powerful and sustained buffering. The Henderson-Hasselbalch equation pH 6.1 log HCO/0.03 PaCO describes this system. Option A, the phosphate system HPO/HPO, is important intracellularly and in the urine, but is a minor buffer in the ECF due to low concentration. Option B, protein buffers, especially imidazole group of histidine in hemoglobin, are crucial inside cells like red blood cells and for buffering metabolic CO, but are not the primary ECF buffer. Option D is a renal mechanism for excreting acid, not a primary circulating buffer. Question 2. In the countercurrent exchange mechanism, the vasa recta maintain the medullary concentration gradient by Option A. Actively pumping sodium into the interstitium. Option B. Passively allowing diffusion of solutes and water along their gradients as blood flows slowly through the medulla, minimizing washout of the gradient. Option C. Secreting urea into the collecting duct. Option D. Constricting in response to angiotensin II. The answer is B. The countercurrent multiplier loop of Henle creates a hypertonic medulla. The blood vessels supplying the medulla, the vasa recta, must retrieve water and solutes without destroying this gradient. They do so via a countercurrent exchange mechanism. The vasa recta are hairpin-shaped capillaries that run parallel to the loops of Henle. Blood flows slowly down into the medulla and back up. As blood descends into the hypertonic medulla, water diffuses out of the capillary into the interstitium and solutes, NaCl, urea diffuse in, concentrating the blood. As blood ascends back toward the cortex, the opposite happens. It now contains higher solute concentration than the surrounding, slightly less concentrated interstitium, so solutes diffuse out and water diffuses in. This passive exchange along the entire length means that by the time blood leaves the medulla, it has picked up water and solutes, but the net removal of solute from the medulla is minimized. This preserves the osmotic gradient. Option A is the job of the thick ascending limb. Option C is a function of the collecting duct. Option D is a systemic regulatory mechanism, not specific to vasa recta function. Question 3. Fanconi syndrome is a disorder of the proximal tubule. What is the general defect and a common clinical manifestation? Option A. Generalized dysfunction of all proximal reabsorption mechanisms, leading to glycosuria, aminoaciduria, phosphaturia, and type 2 RTA. Option B. Isolated defect in water reabsorption, causing nephrogenic DI. Option C. Defect in sodium-potassium exchange, causing hypokalemia and alkalosis. Option D. Inability to secrete hydrogen ions, causing type 1 RTA. The answer is A. Fanconi syndrome is not a single disease, but a syndrome of generalized proximal tubular dysfunction. The proximal tubule normally reabsorbs a vast array of filtered substances: glucose, amino acids, phosphate, uric acid, bicarbonate, and low molecular weight proteins. In Fanconi syndrome, there is a defect in the transporters or energy supply for this reabsorption. This leads to excessive urinary loss of all these substances: glycosuria, sugar in urine despite normal blood glucose, aminoaciduria, phosphaturia causing hypophosphatemia and rickets/osteomalacia, uricosuriya, and bicarbonaturia. The loss of bicarbonate causes a proximal type 2 renal tubular acidosis (RTA). It can be inherited, e.g., cystinosis, or acquired, e.g., from multiple myeloma, heavy metals. Option B describes nephrogenic diabetes insipidus, a defect in the collecting duct's response to ADH. Option C could describe the effect of some diuretics or Bartter syndrome. Option D describes distal type 1 RTA, where the collecting duct cannot secrete H effectively. Question 4. The fractional excretion of sodium FeNA is a useful diagnostic test in oliguric renal failure. Which calculation is correct for FeNA? Option A. Urine Na/serum Na/urine creatinine/serum creatinine 100. Option B. Serum creatinine/urine creatinine urine Na/serum Na. Option C. Urine Na/plasma Na/urine creatinine/plasma creatinine 100. Option D. Urine osmolality/plasma osmolality/urine Na/plasma Na. The answer is C. The fractional excretion of sodium FeNA measures the percentage of filtered sodium that is excreted in the urine. It helps distinguish prerenal from intrinsic renal causes of acute kidney injury (AKI). The correct formula is FeNA urine Na/plasma Na/urine creatinine/plasma creatinine 100. The logic: urine Na/plasma Na is proportional to the amount of sodium excreted relative to what's in the plasma. Urine creatinine/plasma creatinine is proportional to the fraction of filtered creatinine excreted, which approximates the glomerular filtration rate (GFR), since creatinine is freely filtered and not reabsorbed. By taking the ratio of these two, you get the fraction of filtered sodium that is excreted. Multiplying by 100 gives a percentage. In prerenal states low perfusion, the kidney avidly reabsorbs sodium, so FeNA is typically 1. In intrinsic renal failure, e.g., ADN, tubular reabsorption is impaired, so FeNA is usually 2. Option A is close, but missing the parentheses grouping the ratios. Option B is an incorrect rearrangement. Option D uses osmolality and a multiplication, which is not the standard FeNA formula. Question 5. Parietal cells in the gastric glands secrete hydrochloric acid. What is the final common transporter on the apical membrane that directly secretes H ions into the gastric lumen? Option A. The Na/H exchanger NHE. Option B. The H/K ADPase proton pump. Option C. The carbonic anhydrase enzyme. Option D. The chloride bicarbonate exchanger AE2. The answer is B. The secretion of concentrated hydrochloric acid HCl into the stomach lumen is an energy-intensive process. The key player is the H/K ADPase, also known as the proton pump. This is an active transport protein located on the apical luminal membrane of parietal cells. It uses energy from ATP hydrolysis to pump hydrogen ions H against a massive concentration gradient from the cell cytoplasm into the stomach lumen. Simultaneously, it imports potassium ions K into the cell. This is the final, direct step of acid secretion. The other components support this pump. Carbonic anhydrase inside the cell catalyzes the formation of H and HCO from CO and water. The HCO is exchanged for Cl from the blood via a basolateral Cl/HCO exchanger AE2. The Cl then exits into the lumen through channels, combining with H to form HCl. Option A, the Na/H exchanger, is used in many cells including the kidney for pH regulation and sodium reabsorption. But it is not the primary acid pump in the stomach. It cannot generate the large H gradient needed. Option C, carbonic anhydrase, produces the H but does not transport it. Option D is the basolateral exchanger that brings in Cl. Question 6. Celiac disease is characterized by an immune-mediated reaction to gluten. What specific component of gluten is the antigenic trigger, and what is the primary site of intestinal damage? Option A, albumin, causes damage primarily in the colon. Option B, gliadin, causes villus atrophy and crypt hyperplasia in the duodenum and jejunum. Option C, lactose, causes osmotic diarrhea in the ileum. Option D, gliadin, causes hypertrophy of the muscularis mucosa in the stomach. The answer is B. Celiac disease is an autoimmune disorder triggered by the ingestion of gluten, a protein found in wheat, barley, and rye. The specific antigenic components are gliadins and glutenins, which are the alcohol-soluble fractions of gluten. In genetically susceptible individuals, these peptides are partially digested and then deamidated by the enzyme tissue transglutaminase TTG in the small intestinal mucosa. The modified peptides are presented by antigen-presenting cells, triggering an adaptive immune response, both T-cell and antibody-mediated. This immune attack is directed against the intestinal lining. The primary site of damage is the duodenum and proximal jejunum, the first part of the small intestine. The characteristic histological findings are villus atrophy, flattening of the finger-like projections that absorb nutrients, crypt hyperplasia, increased depth of the crypts as the body tries to regenerate, and an increase in intraepithelial lymphocytes. This damage leads to malabsorption. Option A, albumin is not the trigger. Option C, lactose is a sugar, and its intolerance is a different condition. Option D, the stomach is not the primary site of damage in celiac disease. Great job! Don't forget to subscribe. Bye!